Normal pressure hydrocephalus is one of the few causes of dementia-like symptoms in adults over 65 that is surgically treatable. According to research published in the journal Neurosurgery, between 10 and 15% of adults diagnosed with dementia may actually have normal pressure hydrocephalus, and a significant proportion of those patients experience meaningful improvement in walking, bladder control, and cognition after cerebrospinal fluid drainage through a surgically implanted ventriculoperitoneal shunt. Yet despite this remarkable treatment potential, the average time from the first symptom of normal pressure hydrocephalus to diagnosis and treatment is 3 to 7 years, during which the enlarged ventricles continue to compress the surrounding white matter, and the window for maximal shunt response progressively narrows. Normal pressure hydrocephalus is a condition in which cerebrospinal fluid, the clear liquid that circulates through the ventricular system of the brain and through the subarachnoid space surrounding the brain and spinal cord, accumulates inside the lateral ventricles and the third ventricle because its reabsorption through the arachnoid granulations overlying the cerebral convexities is impaired. Unlike acute hydrocephalus, where rapid intracranial pressure elevation from blocked cerebrospinal fluid flow produces a surgical emergency with severe headache and loss of consciousness within hours, normal pressure hydrocephalus develops gradually over months to years. The cerebrospinal fluid pressure measured by lumbar puncture with a manometer performed at the L3, L4, or L4, L5 intervertebral space with the patient lying on their side is within the normal range between 7 and 18 centimeters of water in normal pressure hydrocephalus despite the ventriculomegaly, the enlargement of the ventricles visible on computed tomography or magnetic resonance imaging of the brain. This normal cerebrospinal fluid pressure despite enlarged ventricles is the paradox that gives the condition its name, and that makes it so difficult to recognize without brain imaging. According to data from the Hydrocephalus Association, approximately 700,000 Americans have normal pressure hydrocephalus, but fewer than 20% receive the correct diagnosis in their lifetime. The condition is underdiagnosed because its 3 cardinal symptoms, a specific type of walking difficulty, urinary incontinence, and cognitive slowing, are individually and collectively attributed to the most common conditions in adults over 65. Parkinson's disease, overactive bladder syndrome, Alzheimer's disease, and normal aging. The correct diagnosis is established when brain magnetic resonance imaging shows ventriculomegaly disproportionate to cerebral atrophy, and when a large volume lumbar puncture draining 30 to 50 milliliters of cerebrospinal fluid produces measurable improvement in gait and cognition within 24 to 72 hours. In this video, I will walk you through 10 early signs of normal pressure hydrocephalus, including the signs that appear before the classic triad is fully established. Before we begin, this video is for educational purposes only. Normal pressure hydrocephalus requires diagnosis through brain magnetic resonance imaging with specific volumetric measurements, lumbar puncture, and evaluation by a qualified neurologist or neurosurgeon. If you recognize multiple symptoms from this list, contact your physician and ask specifically for brain magnetic resonance imaging to evaluate ventricular size and for neurological evaluation for normal pressure hydrocephalus. Let me first explain what happens inside the brain when cerebrospinal fluid accumulates in the ventricles, because understanding this pressure on the surrounding brain tissue explains every warning sign that follows. The lateral ventricles are 2 C-shaped fluid-filled cavities, one inside each cerebral hemisphere. They connect through the foramen of Monro to the third ventricle in the center of the brain, which connects through the cerebral aqueduct of Sylvius to the fourth ventricle between the pons and the cerebellum. Cerebrospinal fluid, produced by the choroid plexus lining the ventricles at a rate of approximately 500 milliliters per day, flows from the lateral ventricles through the third ventricle and fourth ventricle into the subarachnoid space, where it bathes the surface of the brain and spinal cord before being reabsorbed by the arachnoid granulations projecting into the dural venous sinuses along the top of the skull. When reabsorption through the arachnoid granulations is impaired, cerebrospinal fluid accumulates and the ventricles enlarge. As the lateral ventricles expand, they compress the periventricular white matter tracts that run adjacent to their walls. These periventricular white matter tracts include the corona radiata connecting the cortex to subcortical structures, the anterior limb of the internal capsule carrying frontopontine fibers from the frontal lobe to the brainstem, and most critically the corticospinal tract carrying motor commands from the motor cortex to the spinal cord, and the leg control fibers that run in the medial parasagittal region closest to the lateral ventricle wall. The leg motor fibers are arranged in the medial part of the corona radiata, directly adjacent to the lateral ventricular wall, which is why gait disturbance is the earliest and most prominent symptom of normal pressure hydrocephalus. The bladder control fibers also run in the periventricular white matter adjacent to the ventricles, explaining why urinary urgency and incontinence are early features. The frontal lobe connections to the basal ganglia and thalamus that support working memory and processing speed run through the anterior periventricular white matter, explaining the cognitive slowing. Now let us go through all 10 signs. Sign number 10, a very gradual change in walking pattern developing over months to a year or more, in which the stride length shortens, the feet lift less from the ground, the walking speed slows, and turns require multiple small steps rather than a single smooth pivot. The gait of normal pressure hydrocephalus is one of the most recognizable gait patterns in neurology and has specific features that distinguish it from the gait of Parkinson's disease, from cerebellar ataxia, and from peripheral neuropathy. The person walks with their feet wide apart to maintain balance, with short shuffling steps in which the feet barely clear the floor surface and slide or scuff the ground. They walk slowly with reduced arm swing, and they need to stop and take multiple small steps to turn around rather than pivoting smoothly. When asked to walk faster, they cannot significantly increase their cadence or stride length because the ventriculomegaly has compressed the periventricular corticospinal fibers that normally allow rapid voluntary modulation of gait speed. The key feature that distinguishes normal pressure hydrocephalus gait from Parkinson's disease gait is the response to sitting versus standing. A person with Parkinson's disease who sits down continues to show the cardinal Parkinson's features, including resting tremor of the hand at 4 to 6 cycles per second and cogwheel rigidity when the examiner passively flexes and extends the wrist. A person with normal pressure hydrocephalus gait who sits down loses the gait abnormality completely when sitting because the gait disorder is a motor output problem from compressed periventricular tracts rather than a Parkinsonian dopaminergic deficit. The Tinetti Gait and Balance Assessment, which scores gait initiation, step length, step symmetry, walking continuity, path deviation, and trunk stability on a scale from 0 to 12, and the Timed Up and Go test, which measures in seconds the time required to stand from a chair, walk 3 meters, turn around, return to the chair, and sit down again, provides standardized quantitative measurements of gait severity for baseline documentation and shunt response monitoring. Sign number 9, increased frequency of urination during the day, urgent need to urinate that is difficult to delay, and episodes of urinary leakage before reaching the bathroom, occurring in a person who did not previously have bladder control problems. Urinary urgency and incontinence in normal pressure hydrocephalus result from compression of the periventricular white matter tracts that carry the inhibitory frontal lobe signals to the pontine micturition center in the brainstem. The frontal lobe, particularly the medial prefrontal cortex and the anterior cingulate cortex, exerts continuous inhibitory control over the pontine micturition center through the periventricular white matter. This frontal inhibition prevents the detrusor muscle of the bladder from contracting involuntarily until the person chooses an appropriate time to void. When the periventricular white matter is compressed by the enlarged lateral ventricles, this frontal inhibitory signal is interrupted, and the pontine micturition center activates detrusor contractions at lower bladder volumes without frontal suppression. urodynamic cystometry, which measures the intravesical pressure during bladder filling through a urodynamic catheter placed in the bladder, shows uninhibited detrusor contractions occurring at volumes below 200 milliliters in patients with normal pressure hydrocephalus, compared to the normal first urge to void at 300 to 500 milliliters. The urinary symptoms of normal pressure hydrocephalus improve significantly in the majority of patients following cerebrospinal fluid drainage by lumbar puncture or by ventriculoperitoneal shunt, confirming that they result from reversible periventricular white matter compression rather than irreversible bladder pathology. Sign number 8, slowing of mental processing speed. Difficulty retrieving information quickly during conversation, and reduced ability to maintain attention on complex tasks without the dense episodic memory loss typical of Alzheimer's disease. The cognitive profile of normal pressure hydrocephalus is a subcortical pattern reflecting the compression of frontal-subcortical white matter circuits rather than direct cortical neuronal damage. The person thinks more slowly. They take longer to respond to questions because the frontostriatal circuits that normally maintain rapid cognitive processing depend on the integrity of the anterior periventricular white matter. They have difficulty switching between tasks efficiently. They cannot hold multiple pieces of information in working memory simultaneously as effectively as before, but they can usually recall events from yesterday and the day before with reasonable accuracy, because the hippocampus, which encodes episodic memories, is in the medial temporal lobe far from the compressed periventricular white matter and is relatively spared in normal pressure hydrocephalus. This preserved episodic memory alongside reduced processing speed is a crucial distinguishing feature from Alzheimer's disease, where episodic memory loss is the earliest and most prominent deficit. The frontal assessment battery, which assesses frontal lobe functions, including concept formation with verbal similarities, motor programming with the Luria sequences, sensitivity to interference, inhibitory control with the conflicting instructions task, environmental autonomy with the prehension behavior task, and word generation with phonemic fluency, provides a focused assessment of the frontal-subcortical cognitive impairment characteristic of normal pressure hydrocephalus. The digit symbol coding subtest of the Wechsler Adult Intelligence Scale provides a sensitive measure of processing speed that is reduced in proportion to the severity of periventricular white matter compression. Sign number 7, falls that occur particularly when attempting to start walking from a standing position, when turning, or when negotiating uneven ground without any dizziness, loss of consciousness, or cardiac event preceding the fall. Falls in normal pressure hydrocephalus result from the instability of the specific gait abnormality described in sign number 10, combined with the reduced ability to generate rapid balance-correcting responses when balance is disturbed. The periventricular white matter tracts adjacent to the lateral ventricles carry not only the voluntary gait commands from the motor cortex, but also the rapid reflex motor responses from the supplementary motor area and the premotor cortex that correct for unexpected balance disturbances. When these tracts are compressed, the speed and amplitude of the balance-correcting stepping responses that prevent a fall after an unexpected perturbation are reduced. The person stumbles when their foot catches slightly on a rug edge because they cannot generate a rapid stepping response to recover before falling. They fall when turning because the turn requires a rapid lateral weight transfer that the compressed periventricular tracts cannot support efficiently. Sign number 6, difficulty rising from a low chair or sofa, requiring multiple attempts, pushing on the armrests, and rocking forward before being able to stand successfully. Rising from a seated position requires the generation of rapid extension torque at the hips and knees combined with forward trunk lean and weight shift, all of which depend on the frontal lobe motor planning circuits and the supplementary motor area that coordinates sequential lower limb movements. In normal pressure hydrocephalus, the compression of the anterior periventricular white matter carrying frontal motor planning signals produces an apraxia of gait and stance, meaning the feet know how to walk, but the brain cannot efficiently initiate and sequence the movements required to begin walking or to rise from sitting. observing whether a patient can rise from a standard chair without using their arms, which requires approximately 70% of maximum quadriceps strength versus a low soft sofa, which requires approximately 100% of maximum quadriceps strength alongside adequate motor sequencing from frontal circuits, reveals the contribution of motor apraxia to the rising difficulty in normal pressure hydrocephalus. Sign number 5. Headache that has been present persistently for weeks, located in the frontal region above the eyes or across the forehead, that is not explained by sinusitis, tension, or any identified intracranial abnormality other than the ventriculomegaly. Headache in normal pressure hydrocephalus is not always present, but when it occurs, it reflects the distension of pain-sensitive dural structures by the enlarged ventricular system pushing the brain outward against the inner surface of the dura. The dura mater, the tough outer membrane surrounding the brain, contains pain-sensitive nerve fibers innervated by the trigeminal nerve superiorly and the upper cervical nerves posteriorly. When the lateral ventricles enlarge significantly, they push the cerebral hemispheres outward, stretching the dura and generating a dull, pressure-like frontal or bifrontal headache. This headache may worsen in the morning after overnight recumbency, when cerebrospinal fluid pressure is at its peak, and may improve partially after the person sits upright and cerebrospinal fluid redistributes toward the lumbar region. A large volume lumbar puncture, removing 30 to 50 milliliters of cerebrospinal fluid, produces immediate relief of the headache in many patients with normal pressure hydrocephalus. And this headache response to lumbar puncture can be used as supporting evidence for the diagnosis. Sign number 4. New episodes of urinary incontinence occurring during sleep, meaning the person wakes to find that they have wet the bed, when this was not previously a problem. Nocturnal urinary incontinence in normal pressure hydrocephalus results from 2 compounding mechanisms. The daytime urinary urgency from frontal lobe disinhibition of the pontine micturition center persists during sleep, when the reduced arousal of the sleeping brain further impairs the frontal suppression of involuntary detrusor contractions. At the same time, the reduced mobility from the gait disorder slows the response to the urge to void during partial arousal from sleep, so the person cannot reach the bathroom before bladder contraction produces involuntary voiding. In clinical practice, nocturnal urinary incontinence in an adult over 65 who also has gait abnormality and cognitive slowing constitutes a clinical presentation that should trigger brain magnetic resonance imaging evaluation for normal pressure hydrocephalus before the patient is prescribed anticholinergic medications for overactive bladder syndrome. Sign number 3. Ventriculomegaly visible on computed tomography or magnetic resonance imaging of the brain performed for any reason, showing lateral ventricles that are enlarged out of proportion to the degree of cerebral atrophy, with an Evans index greater than 0.3. The Evans index is the most widely used radiological measurement for ventriculomegaly in normal pressure hydrocephalus. It is calculated by dividing the maximum width of the frontal horns of the lateral ventricles in millimeters by the maximum internal width of the skull at the same axial level. An Evans index greater than 0.3 indicates that the frontal horns are enlarged relative to the skull width beyond what would be expected from normal aging-related cerebral atrophy. On magnetic resonance imaging, the coronal T1 sequences provide the clearest visualization of the lateral ventricles, the third ventricle, the aqueduct of Sylvius, and the fourth ventricle. Additional magnetic resonance imaging findings supporting normal pressure hydrocephalus include a narrowed superior cortical subarachnoid space at the vertex of the skull despite the enlarged ventricles, indicating impaired subarachnoid cerebrospinal fluid circulation, disproportionately enlarged subarachnoid space hydrocephalus in the Sylvian fissures bilaterally, callosal angle below 90 degrees measured on coronal magnetic resonance imaging at the level of the posterior commissure, indicating medial compression of the cerebral hemispheres by the enlarged ventricles, and periventricular T2 fluid attenuated inversion recovery hyperintensity from cerebrospinal fluid transependymal flow into the periventricular white matter. Sign number 2. Positive response to a large volume lumbar puncture, showing measurable improvement in gait speed, stride length, and balance within 24 to 72 hours of removing 30 to 50 milliliters of cerebrospinal fluid. The large volume lumbar puncture tap test is the most clinically useful diagnostic procedure for predicting which patients with normal pressure hydrocephalus will benefit from ventriculoperitoneal shunt surgery. The procedure is performed with the patient in lateral decubitus position using a 22-gauge spinal needle at the L3, L4, or L4, L5 intervertebral level. Opening pressure is measured with a manometer and recorded, followed by slow removal of 30 to 50 milliliters of cerebrospinal fluid over 10 to 15 minutes. Gait is assessed before the procedure and again at 24 and 72 hours after using standardized quantitative measures, including the 10-meter walk test and the timed up and go test. A positive tap test response, defined as improvement in gait speed greater than 20% or reduction in timed up and go test time greater than 20%, predicts a positive response to shunt surgery with a specificity of approximately 90%. A negative tap test response does not reliably exclude shunt response. An extended lumbar drainage of cerebrospinal fluid through a lumbar drain for 3 to 5 days provides higher sensitivity for predicting shunt response in patients with negative tap tests. Sign number 1. The complete or partial classic triad of magnetic gait with short shuffling steps and wide base, urinary urgency and incontinence, and subcortical cognitive slowing with frontal features, occurring together in the same adult over 65 with no alternative neurological diagnosis fully explaining the combination. This triad, described by Hakim and Adams in their original 1965 paper in the Journal of the Neurological Sciences that defined the syndrome, is present in its complete form in approximately 50 to 75% of confirmed normal pressure hydrocephalus cases. The partial triad, most commonly gait disturbance alone or gait disturbance with one of the other two features, is present in the remaining cases and should still prompt brain magnetic resonance imaging evaluation. The neurosurgical evaluation for ventriculoperitoneal shunt placement includes assessment of shunt candidacy based on the severity and duration of symptoms, the degree of ventriculomegaly on magnetic resonance imaging, the tap test response, and the absence of contraindications, including active intracranial infection or severe cerebral atrophy that would indicate insufficient reversible periventricular compression for meaningful shunt benefit. Here is exactly what you need to do right now. If you or someone close to you has a combination of any 2 or 3 of the signs described in this video, contact your physician this week and ask specifically for brain magnetic resonance imaging with measurement of the Evans index and evaluation for normal pressure hydrocephalus. Ask whether a neurologist or a neurosurgeon with experience in normal pressure hydrocephalus should evaluate the imaging results. Ask whether a large volume lumbar puncture tap test is appropriate to assess whether cerebrospinal fluid drainage produces measurable gait improvement. Report the gait symptoms with specific language. Do not say your loved one walks slowly. Say their stride length has shortened, their feet shuffle close to the ground, and they need many small steps to turn around. These specific descriptions alert a neurologist or neurosurgeon to consider normal pressure hydrocephalus rather than attributing the gait change to arthritis or general weakness. If this video helped you recognize a pattern that you had been attributing to Alzheimer's disease, Parkinson's disease, or normal aging, please click the thumbs up button right now. Normal pressure hydrocephalus is the most treatable cause of dementia-like symptoms in adults over 65. And the difference between early treatment and late treatment is measured in years of functional independence. Subscribe to this channel and turn on the bell notification. Share this video with every family caring for an adult over 65 who has walking problems, bladder urgency, and cognitive slowing occurring together. Drop a comment below right now. Type learned if you are requesting brain magnetic resonance imaging this week. Type shared if you are sending this to a family that needs to see it. Thank you for watching this entire video. 10 early signs appear before normal pressure hydrocephalus causes irreversible periventricular white matter damage. Now, you know every one of them.